welcome you all for our monthly webinar series, the Scope and Trocar series. So, this is episode one, wherein we will be focusing on the electrosurgery. So, electrosurgery is one of the most vital part in endoscopic procedures because most of the surgical procedures now are being accomplished by the electrosurgical process. So, one needs to understand the basic physics of the electrosurgical unit, and also we need to know what exactly these do to the tissues. So we need to be a cognitive surgeon to make sure that we are getting a good surgical outcome and patient safety. Keeping that in mind, we have framed this particular episode of the Scope and Trocar series, where we will be focusing on the first generation, second generation, and the current one, the third generation electrosurgeries. So, may I request our president of IAGE, Dr. Kalyan Bamde, to welcome the audience.
Thank you, Mala.
So we have a very eminent, dynamic, and a young president for IAGE. This is his novel idea to start this monthly webinar. So I would like to request him to address all of you all.
Thank you, Dr. Mala. Welcome all for this webinar, and welcome everybody to the team of IAGE 25-26. This year, we have planned many activities, out of which important is target audiences, conferences like target fibroid, target hysterectomy, target endometriosis, target fertility enhancing surgeries. Also will be available online twice in a month. First Friday, we'll be taking this Scope and Trocar series. And last Friday or Saturday, we are going to take UVA Scope and Trocar series also, where UVA endoscopic surgeons are to be entertained, and what are the problems with them will be discussed, and also how a mobile endoscopic surgeon should go ahead in his practice. We are going to discuss the same thing. Today, welcome everyone for Scope and Trocar series webinars. We are going to highlight various aspects of energy sources which is not generally touched upon in daily practices. That is starting from first generation to third generation energy sources, that is basics monopolar to microablation techniques. Speakers will talk for 30 minutes each, and at the end, there will be a question and answer for 15 minutes at the end of the session. I am thankful to convener Dr. Malaraj and coordinator Dr. Mohil Patel for all the cooperation. All chairperson, Dr. Krishna Kumar sir, Dr. Chitra, Dr. Prabha Desai, and the most important three speakers of the day, Dr. Sanket Pisat. Everybody now knows Sanket. He's a UVA endoscopic surgeon, and he has so many innovative techniques he has developed on his name. We are proud of you, Dr. Sanket, and welcome to the webinar. And Dr. Ashish Kale, he's an endoscopic surgeon as well as IVF consultant who is roaming around all of the India from Pune to Arunachal Pradesh to Dubai also. So welcome, Dr. Ashish. And we have a foreign faculty from China, Dr. Jioming Guang. Welcome, sir, for this webinar. He is going to talk on the third generation of the energy sources. Thank you, everybody, for attending this webinar. And we are coming live on first Friday of every month for this series. Our aim is to establish a formal training in surgical energy sources for surgeons and your training staff to provide safe laparoscopic surgery. At the end, we want a litigation-free practice, which is very important in today's era. Thank you, everybody, and happy learning, happy endoscopic time. Thank you so much.
Thank you, sir.
Yeah, thank you so much. So we move on to the invocation. We seek the blessing of the Almighty for the success of this webinar series. Thank you so much. So we've start the first session with the first generation energy sources. Uh, is Dr. Mohil there?
Yes, ma'am.
Yeah, so Dr. Mohil is a very, very young and upcoming endoscopic surgeon, and he is a MC member also of IAGE. So, may I request Dr. Mohil to introduce our chairperson, and the chairperson would invite the speakers.
Uh, Hello, everyone. I'm extremely sorry my video is not working today. I'm extremely sorry for that. Our first chairperson for this session is Dr. Chitra. Professor Chitra T is an multiple others in her doctor degree, fellowship in reproductive medicine and minimal access surgery, certificate course in advanced research methodology in JIPMER, affiliation with the Jawahar Institute of Postgraduate Medical Education and the Research, JIPMER Pondicherry in India, and award of Dr. Purnima Nadkarni ISAR 2020 and Dr. Asha Rao Award in ISAR 2070 and various others awards she has in her name, and best paper presentation has also done in various societies, and Wonder Foxian Award 2019 goes to her, and Dhira Award 2022 and facilitated by Foxy President and Indian Fertility Society and Achievers Awards by IFS 2022, and she has various publication on her name, and her area of interest is reproductive medicine, especially in PCOS and endometriosis, laparoscopy, fertility enhancing surgery, and medical education. And stage is all yours, Dr. Chitra. Kindly introduce doctors. Thank you.
Thank you so much for the kind introduction, and it is a really a wonderful initiative by Kalyan sir and Malaraj ma'am getting this, because I think nowhere I've seen a laparoscopic webinar series happening covering from the basic aspect to the advanced stage. So I really thank sir for this really initiative and Mala ma'am to working behind this and giving me the opportunity to chair this session. Can you put the please slide of the speaker? Yeah, so it is very my privilege to introduce Dr. Sanket Pisad. He is a consultant in endoscopic surgery in Mumbai. He has did fellowship in gynec endoscopy and is also a member of managing council in Mumbai Ops and Gynae Society. He has published various innovations. That's very nice to know that he has devised Pisad's visual vasopressor injection needle, and also is devised shoelace, not a method for reversible ligation of uterine artery and its origin in patient undergoing myomectomy, and he has got an award Make in India. It's a Healthcare Innovation Award by Professor Rajendra Prasad Gupta, and also Dr. Pramila Bhatia Young Scientist Award from Mumbai Ops and Gynae Society. So we are very happy to hear to Dr. Sanket. As we know, energy sources forms a part and parcel of laparoscopy, whether it is for dissection, tissue retrieval, whatever. Without that, we cannot exist. So let us hear to you for the first energy sources. Okay, over to you, Sanket.
Thank you, madam. Thank you for that kind introduction. First of all, I'd like to thank Dr. Kalyan Barmade, Dr. Malaraj, and everyone at IAG for giving me this opportunity today. And it is indeed very heartening to see so many people interested in learning gynae endoscopy. So, if my video and slides are visible, may I please start?
Yeah, yeah,
Right.
it's fine.
Okay.
Yes, sir. It's
So,
visible.
thank you. So, when we talk of electrosurgery and energy sources, it is very important, like Dr. Malaraj said when we started, to understand right from the basics upwards. And for my part, I will be covering the very basics, which is monopolar energy, bipolar energy, and a little bit about the seal and cut technology indigenously developed in India, which we refer to as the bipolar shear. So when we talk of types of energy, there are generally four types of energy that we consider in endoscopy: monopolar, bipolar, advanced bipolar, or vessel sealing. They mean the same thing. They are also called sometimes as smart bipolars or fourth generation bipolars, and ultrasonic energies. Any energy that we use falls under the realm of one of these four energy sources. Before we start, some key concepts about energy. Usually, a frequency of between 1 to 100 kilohertz causes neuromuscular stimulation, and whenever the energy is above 100 uh, kilohertz, neuromuscular stimulation stops. As far as electrosurgery is concerned, we operate far above this band. So we operate between 200 kilohertz to 3.3 megahertz, which is why during surgery, unless you touch a muscle belly or you touch a nerve with your current, the patient does not move. And while doing routine coagulation or cutting, there is never a tonic clonic seizure of muscles which is observed when the surgeon is operating on the field. Uh, to understand certain key components, some physics is required for understanding the basics of electrosurgery. And so, with that concept, electrical circuit always has three components. Okay, so there is always the source or the generator which generates the current. There is a closed circuit, which means that the current has to go pass through the resistance of the patient and make its way back to the machine, without which the current will not flow. And third is a resistance or the patient. Now, it is important to understand that unless the current is given a free flow path from here to here and back to the machine, the current will just not flow. It is not that it will flow a little bit and then stop, it will not flow at all. So, having understood that, let's look at three different types of energies that we have. The first one is monopolar energy. And when we talk about monopolar energy, we talk of monopolar energy in three separate forms. These forms are available in newer machines as various names or various methods, but the underlying principle remains the same. You can either have cutting current, coagulating current, or blended current. So it has to be one of these three currents. And the again principle remains the same. The current is generated from here, it will pass from here, it will pass through the active instrument to the patient, back to the return plate, and then back to the machine. So let's see cutting and coagulating waveforms and how they are actually different. You know that we use the same machine and the same pencil point for cutting as well as coagulation. So does it happen that the machine knows when to cut and the machine knows when to coagulate using exactly the same set of instruments? So what happens in cutting? In cutting, imagine this as a cell, and there is continuous heating of the tissue which is made available to the cell. Because of this continuous heating, the cell intracellular fluid is not given any time to cool off. And the sudden heating of the cell causes expansion of the intracellular fluid, and this cell explodes because of heat. This exploded cell, which is seen as a cellular explosion at the microscopic level, is seen as a desiccation of tissue or separation of tissue at the macroscopic level. And that is how cutting current works. When we move to coagulation, there is a short but intense heating of the tissue, which is more or less the same as cutting. But in coagulation, this is followed by an off period, or in other words, a cooling off period. What happens because of the cooling off periods? The liquids do not get superheated, they get time to dry up. And when they get time to dry up, these liquids disappear. And this pause moment creates a dried or coagulated cell, which then results in hemostasis. So, same current, but deployed in different ways, resulting in different actions on the tissue. How do the waveforms differ? So this is the current waveform, and this we are talking on the left of pure cutting current and on the right of coagulating current. You can see in the pure cutting waveform, the amplitude of the waveform is less. That means the up down strokes are less, but the waves are appearing at more frequent intervals. So you have got a waveform which is appearing at a higher frequency between the two waves, but at a lesser amplitude. And if you look at the right of the picture, this is the same waveform, but this waveform has got a much higher amplitude but a lesser frequency. This gap between the two waves, so you can see 100% on the left side versus 6% on and 94% off on the right side. It is this gap which provides for coagulation and does not allow cutting. So on the left, high frequency waves of lower amplitude or lower voltage causing the cutting effect, and on the right, higher voltage waves but with less frequency causing coagulation effect. And this is the main difference between the two waveforms. So between cut and coag, how does it differ? The frequency is high and in coag it is low. The amplitude is the other way around, and the net result of effect on the tissue, in cutting current, you get a fine cut with minimal lateral spread. So if I were to play this video, I hope the video is playing. If the You can see that in the first one, this is the pure cutting waveform which is being used, and a straight line is being created. When I switch to a blended or a coagulating waveform, I get a coarse cut with some more lateral spread. And here, when I'm using, that was the blended one. And in the third one, when we are using the coagulating waveform, you can see how much lateral spread is happening. So essentially, the cutting waveform is the waveform used for dissection, and the coag waveform is the waveform used for hemostasis. In endoscopy, it is the cutting waveform would be used for typically for situations like PCO drilling or colpotomy in lapistrectomy, and the coag waveform would be used for controlling bleeding or hemostasis. This is again the same thing how it looks like. You can see here the cut is a smooth cut and the coag is a very ragged and destroyed kind of tissue, denoting how much lateral spread occurs if you change the type of waveform that is used. Then we come to the second very important concept, which is of current concentration and density. Now, we all know that when current enters into the body, it causes coagulation. But when current leaves from the body, it does not coagulate at the return electrode position. So, why does this happen? The answer is in the area of contact. So, when electrons, imagine that a bulk of electrons is entering at this point at a high current concentration, it you are forcing a large number of electrons to enter into the tissue with a very narrow surface area, and this is going to cause a coagulation or a cutting effect. However, when the same electrons leave from the body, they will get spread out over a wider surface area, and therefore this will not cause a burn. The problem that happens is when the return electrode is not well connected, the current entry area and the current exit area, they almost become the same, and therefore the current does not understand that it is not supposed to coagulate at the exit, and that is where you get return electrode burns. This is something what it looks like if the plate has not been connected properly and current is forced to go from all of this area rather than the center of the plate, giving rise to the return electrode burn injury. What are the common mistakes that we as doctors make when we apply return electrode? Applying a return electrode far away from the area of the surgery. You are forcing current to go through a wider path of tissue when it is actually not required. Applying the return electrode over a bony prominence. So whenever you know that traditionally we have been taught to apply return electrodes over the buttocks, over the thighs, or padded areas from where the current will have an additional buffer of subcutaneous tissue or muscle when it escapes. Instead of that, if you apply the return electrode over a bony prominence, even today I see at many places where I go to do visiting surgeries, return electrodes are applied over bony prominences like the shin of the tibia, or they are applied over the forearm where it is just under the proximity of the bone. What will happen is that the current will directly exit from skin from the bony prominence and will go into the bone, thereby creating a minimal area of contact and thereby creating a return electrode burn. Reusing of return electrode gel pads is yet another problem. And you see over here, these are return electrode gel pads. They are fantastic and they can measure the amount of current flowing back into the machine and give you an extra safety feature. But these are meant to be disposable. Once or twice reusing them is understandable, but reusing them again and again, because it is the factory set protocol that the amount of gel that is incorporated in these pads is enough for the return electrode to function. If one damages this by applying excessive gel and wrapping the gel pad, return electrode gel pad, which is disposable, using it again and again, then the machine does not understand the fail-safe feature has been overridden, and then you get return electrode injury. So this is the same concept again. Now we come to some complications that happen commonly while using monopolar energy, and these are important from the real life perspective. They are also important from an exam perspective. So if there are any postgraduates listening to this, this is something that is asked time and again in the exam, maybe sometimes also in the viva. And you have always a debate or a difference of opinion between what is direct coupling, indirect coupling, and different other types of injuries of monopolar current. So let's start with the first injury. This is direct coupling. So imagine that there is an active electrode in close proximity to another metal instrument. This is the active monopolar electrode. I plan to work using this electrode, and this is another metallic instrument in close proximity. What is happening? Current from the active electrode flows through the adjacent instrument through the path of least resistance. Ideally, what should be happening? current from here must flow down into the operated area and then back to the return electrode. However, so here if I were to mark this, generally the what should happen is the current must go from here, right? The current should go from here. It should go into the organ where you're operating, and then it should return to the return electrode, which is placed under the patient's body. However, we know that electricity and saline or water, fluid, by laws of physics, always seek the path of least resistance. And because there is another metallic object right here in close proximity, the current jumps from this object to this object and then goes back into the patient electrode. This results because you have created a pathway of lesser resistance, it potentially damages adjacent structures. And the problem for us is that these adjacent structures are not in the field of view. So if I have to clear this drawing, yeah, anyway. So you can see that if I'm going to be operating on this patient, my field of view is going to be restricted only here. And I will may not see that this return electrode is causing a burn at this point and going back into the parent machine. So the injury is caused to adjacent structures not within the visual field or in direct contact with the secondary instrument. So the current is jumping from the primary to the metallic to a vital organ and then going back to the body. Important point to note, the electrode is in proximity to another metal instrument and not directly touching other instrument. Okay, so this is direct coupling. It can be prevented by avoiding contact or proximity with any other conductive instruments. For example, if you are firing a monopolar electrode, then make sure that you do not have the another metallic instrument in close proximity to that one instrument. Okay. So let's see. Uh, Sorry about that. Right. Okay, so you can see this is an example of the same thing. This is a monopolar electrode. This is a scalpel, which is obviously not connected to anything. And without doing anything, the current is jumping from here to the scalpel and then going back to the return electrode. So this can actually happen during surgery if the current is strong enough and the two metallic instruments are in close proximity with each other. Then we come to the second type, which is called as capacitive coupling. And what is capacitive coupling? Current that is established in tissue or in metal instruments running parallel to but not directly in contact with the active electrode. Imagine a clinical scenario. This is the monopolar electrode, and you have got another metallic instrument covering this. So, like a metallic reducer or a metal inner trocar. What will happen as the current flows? It is like having a current which it is like activating the external metallic instrument by way of current passing through the center of that instrument. So electric current is transferred from one conductor through intact insulation in adjacent conductive materials without direct contact. The simplest example of this is you can see that they demonstrate sometimes this when they demonstrate electrosurgical equipment. If you wind a wire around a tube light, the tube light is not connected anywhere to any source, and you switch on the pedal or you activate the current, just the fact that the wire has wound around the tube light is enough to make the tube light glow, because the current activates the tube light without physically touching or leaking onto the tube light itself. So the point is capacitive coupling happens when current passes through or in the center of another conductor, activating that conductor and causing a damage to the organ which is in contact with that secondary conductor. So I hope this is clear. This is capacitive coupling. Again, here you can see an exemption, type of example of capacitive coupling. Uh, the tube light is being held without anything close to the conductor, and you can see the tube light is glowing. There is no physical leakage of current, and yet the tube light is glowing because it is getting activated just by being parallel to the flow of energy. So that's capacitive coupling. But the commonest one that we face in our practice is insulation failure. This is the main cause of laparoscopic electrical injuries and is defined as a break or instrument in the insulation that coats the instrument. Insulation failure is typically caused by excessive use of reusable instruments. You know, the black coating that we have over the instrument that gets worn out over time, and repetitive passage through trocars and frequent sterilization like autoclaving will damage the external insulation. This can be avoided by using what we call an active electrode monitoring system, but which is a little bit theoretical. But the best is to use disposable electrodes or single use electrodes. And if you are using reusable electrodes, then discard them after a few uses. So this is the active electrode monitoring system. It's not actually used that much in practice, but this is like a brush which is run over the surface of the instrument, and any spike caused by current leakage is noted by the instrument immediately, and you know this instrument has to go for repairs or for replacement. This is again a video of defective insulation. You can see that this, because the insulation is defective, this is then activating the trocar, and the trocar is then burning the skin around it. So you can see over here, this is getting activated by defective insulation. Also, because there is a lesser path of conducting here, this is also getting activated. And in real life, you will get patient electrode burns at the bowel over here and at the abdominal wall over here. Then moving on from monopolar to bipolar energy, a much safer form of energy. In a sense, monopolar is also very safe, but this is safe in the sense that the active and return electrodes are in the same instrument, and hence current flow is confined to the tissue between the two electrodes. So, because current flows directly from one prong of the bipolar instrument to the other prong, it goes to say that a return electrode is not needed in bipolar. Effectively, if you are going to use only bipolar energy, then you do not require a patient electrode return plate. Okay, so I hope that is very clear. You do not require, because the circuit is completed locally. It is not that the circuit is not completed. By principles of physics, it has to be completed, but it is completed locally within the arms of the instrument, and therefore there is no need for you to have a return electrode at all. So again, this is bipolar between two blades of the instrument, and that was monopolar, which I already talked about. Now, there are vessel sealing devices. I am going to not talk about this because Dr. Ashish Kale is going to cover this in detail. So these slides I will skip about how vessel sealing actually works, the mechanism of it, and the concept of impedance. But that Dr. Ashish will be covering. I'll just take a minute to explain this slide before going on to the presentation on the bipolar shear. So always there is a question about lateral thermal spread and which energy source is the safest. So it's actually, this table kind of summarizes the lateral tissue spread that most devices cause, but there are a lot of variables involved. So if you look at monopolar, if you look at the table on the left, you will see that the lateral thermal spread does not just depend on the type of current, it depends on the type of tissue. Means the wetness of the tissue. If the tissue has got more water inside it, let's say you are coagulating bladder. Bladder has got lot of fluid inside it, not in the physical sense, but the cellular fluid is more. Versus if you are cauterizing something like a hard structure, like a round ligament, then the lateral spread is going to be a little less. The time of application of tissue, quick in, quick out, the same type of energy applied will have less lateral spread if the time of application is less. The mode of current, cut versus coagulating. So people ask this question whether monopolar has got less lateral spread or bipolar has got less lateral spread. But in a sense, the question is wrong, because you are not stating whether you are talking about monopolar weather versus monopolar coagulation. And the last effect is compression on tissue. The more you compress the tissue, the easier it is for current to flow from one blade to another, particularly in bipolar. And so, the more the compression on tissue, the less is the lateral spread. And this is one of the premises on which ligashore works, where graded compression is provided between the tissue jaws, and you find that there is minimal lateral spread because the compression is surgeon independent and will flow minimally between the two jaws. With maximum compression will come minimal lateral spread. So on a head to head comparison, if you look at monopolar in the pure cut mode, just 2 to 3 millimeters of lateral spread. So monopolar used properly is not a defective instrument. In fact, now in robotic surgery, you will see extensive use of monopolar current, and that is the fact that if you use in pure cut, the lateral spread is minimal. But if you switch to coag, the lateral spread can be as much as 2 centimeters. For bipolar, in for most applications, 5 to 6 millimeter, and ligation and harmonic 1 to 2 millimeter, but again subject to the variables which are mentioned on the left hand side. This is just a video to illustrate the bipolar coagulation concept and the concept of lateral spread. And you can see when we play the video how the white coagulates and spreads to sides. So this is basically how lateral spread looks like, whether you use monopolar or bipolar. Now, what we are going to do is we are going to look at the other presentation on bipolar shearer. I believe I still have 15 minutes. And this is a presentation on a bipolar shearer or the seal and cut device. This is something I believe which has been indigenously developed in India, and hence a little bit of time to understand this. A lot of people, endoscopic surgeons in India and some outside India as well, are now using this device very effectively and with very great results, since it is a made in India device and it has a lot of features that you should know. I'm going to take the next 10 minutes to explain this device in detail. My disclaimer is that most of electromechanical data is courtesy Allen Electronic Systems India. There are no financial disclosures. And to the best of my knowledge, because Allen holds the patent for this technology, I have tried to summarize the electrosurgical physics part of the talk based on the patent application papers which they have provided to us. So you have already know the concept of how the coagulation and the cutting occurs. So what exactly is this shearer, as we call it? Is it essentially a bipolar device with an impedance feedback? That means the machine understands when a critical limit of tissue resistance is reached. A large chunk of tissue can be grasped. The current will flow from one jaw to another. As the tissue starts getting denatured by flow of current, obviously the resistance to flow between 2 points will keep on increasing. When the resistance reaches a critical preset point, which has been fed into the machine, the control unit beeps and indicates that there is a seal, meaning that you do not need to provide any more current in order to coagulate this tissue. So this is how the machine works in ligate mode, and essentially this is the same method of working of a ligature or any other advanced hemostasis device as well. In the cut mode, how does it change? So this is where it gets really interesting. In the cut mode, I already explained to you the superheating concept and how the exploded cell works. So here a low voltage cutting current is delivered. A small chunk of tissue is grasped and the current exits through a narrow area, providing desiccation of tissue by superheating and bursting of the cell. So this is again the same concept that we would use in monopolar, holding a very small chunk of tissue and forcing the current to exit through narrow jaws. However, how is this concept being used in bipolar? So the point is, generally, if you use bipolar coagulation and you coagulate the tissue will slowly get coagulated until the time that it dries up, resulting in sealing the tissue. Where the shearer differs from the rest of the technology which is available is that at a lower impedance, the unit is able to provide high energy. Okay, so it is able to provide high peak voltage at a lower impedance. So even when that resistance of the tissue is less, the current thrown inside is more, and therefore using bipolar technology itself, the machine is able to cut and coagulate using the same settings, using the same design. This is the original design of the bipolar. They initially introduced it with rounded prongs, and you can see that with this we are able to coagulate. These are the prongs. You can do surface coagulation also, as you would use a Bissinger bipolar or any other bipolar grasping forceps. So that function is retained. When you are using this instrument, the main catch of using this instrument for most of us who are using it regularly is that you are able to ligate and cut in a single instrument. Okay, you can use this instrument for ligating and cutting both. You can see that it provides white coagulation, so there is no charring with an instant cut. So what happens is my other hand remains free. for a surgeon to have multifunctional use in one instrument rather than switching between bipolars and scissors or switching between bipolar and ultrasonic scalpel avoids the need for frequent instrument changes and therefore tremendously increases the speed of the surgery. So you can see I'm doing coagulation and cutting with the same instrument. There are surgeons who are using a bipolar coagulator in one hand and using this instrument purely for cutting, which is also acceptable, like using it like an enhanced scissors. But in my opinion, that is underusing the functionality of the instrument. There are concerns about lateral spread when you use the instrument. I can vouch that this instrument in the cut mode has got minimal lateral spread. It is almost negligible. You can see I'm cutting the UV fold. And if you look carefully at the edges of the cut UV fold, you will find that there is zero charring of tissue. Forget charring. There isn't even a affection of the lateral tissue to state that the tissue was cut. It's almost as if it is a clean cut given by a cold scissor itself. The cutting is immediate. So, unlike the ultrasonic, if I may have a head to head comparison, you do not really have to wait for the machine to go 1, 2, 3, 4 and then cut. The cutting is instant and immediate. There is a curved jaw design available, which is an excellent dissector and tremendously safe for use near vital organs. So, here you can see I'm dissecting the bladder in previous LSCS, and safely I'm able to cut not just the UV fold, I'm able to dissect under the bladder. This is the plane under the bladder which I have created. Once the lateral space and the window has been created, I can directly cut the scar tissue without bothering to have any significant thermal spread that will damage the bladder. It can be used for large vessels as well. So it is not that it can be used only for small vessels, large vessels as well. It takes a little bit of learning curve. The speed of application, the amount of compression, and the type of current used, it's a bit of a learning curve, but it will yield the desired result. Uh, there were concerns of using it close to vital structures in the retroperitoneum, but because it gives an instant cut, there is tremendously easy dissection with the curved jaw. So you can see if you give slow compression and you do not close the blades, then it avoids an inadvertent cut. But when you want an immediate cut, you just have to give some traction on the tissue, hold the tissue, and when you use it in the cut mode, without a second thought, immediately the tissue splits and you are able to go into the next plane of dissection. Also, you can use the same instrument for doing macrocoagulation. Like, for example, here I have exposed the uterine artery. I can hold the uterine artery, and in short bursts, if I apply it, then it will not cut the uterine artery by mistake. Like I said, it is a little bit of learning curve, but a fantastic instrument to learn. Again, coming back to doing ovarian cystectomy and para-ovarian cystectomy, single-handed use, my left hand is completely free to do what I want. I can switch between coag and cut mode as I need. If the small vessels bleed, I can coagulate them then and there. If they do not bleed, I can proceed with cutting as if I'm using the scissor. So it's almost like having a bipolar and scissor in the same hand and automatically like a robotic arm switching between both of these instruments. Hemostasis is provided with cutting even for things like a myoma. You can cut into the tissue bed and you can cut when required, you can coagulate when required, and you can get good hemostasis. There is no need to switch to the bipolar for coagulation. Dissection also can be done as required. You can apply current and you can yourself switch between cut and coag modes, making the instrument very versatile. Here, I would like to mention two specific modifications, both from India, one by Dr. Hemant Kanodia and one by Dr. Jay Mehta. They have designed these tips so that the tips become very narrow and further accentuating the possibility of achieving instant cut by these designs. So you can see by these designs, we are able to work very close to tissue. This is pararectal space dissection. This is ureterolysis, both done using the same bipolar shearer, and I can vouch for the fact that it is perfectly safe if you know how to use it well. The modified design is also used in closed spaces like sacropexy, where you get ultrafine dissection. This is Dr. Hemant's design, which is being used, and there is less chance of lateral spread in normal spaces. So you can see the beautifully moving ureter over here, and we are able to closely dissect over the sacral promontory without any significant scope of lateral spread. I think these are my one or two concluding slide, comparison with peers, I would like to compare it with the ultrasonic and the bipolar. So coagulation of large vessels is available in both, not available in ultrasonic. Efficient cutting with some hemostasis. So cutting is something that routine flat bipolars cannot give you. Ultrasonic can give you, and shearer also. But where it this thing is cost effective and reusability, the shearer is cost effective and reusable, which a little bit where the ultrasonics falls short. But the main thumbs up which I would give it is proudly Indian. It ticks all the correct boxes, and therefore this is my instrument of choice or energy source of choice since the past 10 years or more. Cost and reusability, the cost of generator is averagely between 5 to 6 lakhs. One hand instrument is for only 15,000 rupees, and if it gets damaged, the insert is only for 8 to 10,000 rupees. So about 25 to 30 cases can be done with one insert if used and cleaned properly. What are the limitations? The lateral spread in ligate mode is similar to bipolar, so you have to consider that you're using a bipolar only. Need to dissect a little extra to account for this spread. So you cannot dissect as much as you dissect for a ligature. There will be some you have to dissect a little bit more to account for the lateral spread. There is a learning curve to make it cut and coagulate on demand. The tissue has to be at stretch for efficient cutting, unlike a harmonic where you can just hold flaccid tissue and cut. And smoke formation does present a problem, but it gets reduced if you change your inserts frequently. So I think that's all that I have time for. Thank you so much for your patience and for listening.
Thank you, Dr. Sanket. It's really a wonderful presentation on these basics of monopolar and bipolar, which have been used, and you showed a very good video of their sharer. I think one question I want is, what are these key factors when you choose between monopolar and bipolar when you're using different laparoscopic procedures? What are the factors you think, where should you use this?
Monopolar energy, madam, as such, is still used a lot by expert European surgeons. So, if you see the likes of Professor Marcelo, or if you see many of the European surgeons, they are still using electrosurgery, monopolar electrosurgery. The problem that happens when we are using electrosurgery is that our generators may not be as good as what they are using, and the reusability of instruments when you're using monopolar has to be curtailed. If these two factors are taken care of, monopolar is also an excellent method of using. As far as I am concerned, I'm quite comfortable using the bipolar. And since the time of switching to the seal and cut technology or the shearer, it gives such a multifunctional use that my usage of monopolar energy now is restricted purely to either PCO drilling or sometimes to take incision on a thick myoma capsule. Otherwise, I have almost switched over completely.
Okay. And what do you do? I mean, you can tell the audience, like, how do you minimize the risk of any stake and injuries? What precautions should be taken if at all they're using monopolar?
Yeah, so if you're using monopolar, first of all, a good electrosurgical equipment in terms of the generator. Secondly, whenever you are using your hand instrument, make sure to physically check it once before you put it inside. So there should not be any obvious damage which is seen on the instrument. Otherwise, that will result in a major problem to the patient. Thirdly, you must check whether your grounding electrode, that means your return electrode or patient plate, is applied properly or not. And most of the machines available today have got a good fail-safe mechanism. So if your return electrode is not connected properly, the machine will not deliver current at all. It will not allow you. But what happens with us is we try to override this mechanism by doing certain things that should not be done, like reusing disposable electrodes again and again, tying them to the patient's hand or leg using gauze or bandage, putting gel in between return electrodes when they are meant to be used single time. And all of these have given actually monopolar energy a bad name. When if you look at robotics now, it is really like an eye opener that people are going back to monopolar and using it more effectively than the best available tools in the market. So I think if we use it judiciously and with some understanding of the basics, I think monopolar is equally effective, if not better, than bipolar.
Thank you. And with the sharer having a both function, I think surely now everyone will run to the island to get it. Thank you for the excellent presentation. Thank you so much.
Thank you, madam. Thank you very much.
That was a wonderful presentation, Dr. Sankeet. And there are a couple of questions in the chat also. Someone has asked, like, direct and capacitive coupling, is it only with monopolar?
Only monopolar. Strictly only monopolar.
Sir,
this is a RCOG question, madam. Only monopolar or only monopolar.
Yeah. So what is your thought on antenna coupling?
On which coupling?
Antenna coupling.
Antenna coupling. I don't know this term, madam.
Yeah, so there is a
I don't
escape
know this term.
current from the electrodes, no? Stray current from the electrode to the any cable which is lying close by, even the, like the camera cable and all that. So, and that coming in contact with the patient is antenna coupling. So that is also
Okay. Okay. I will add it to my list for
yes.
next time.
Sir, there is an electronic cloud around
It is
when you
escaping through the air.
continuously giving the current. Na, that is the antenna
All
current.
right.
So that is one.
Sir, there is another question. How to know if your Allen bipolar shearer has passed 30 cases, sir? If the
No, you have
place
to.
you go work in does not
Some other
have
institute.
count
Hmm.
and this does not cut properly, how can you interpret that?
Whenever, so it's not brand specific. You can say think of any brand. The point is if your shearer does not cut as easily as it does in the first case, then you have a problem immediately. Means you, if you have to reapply the shearer again and again on tissue, and you have to bite on it and nibble it on it again and again for cutting the tissue, that is the first sign that the shearer has become old. The second sign is that between the first case and the 20th case, the amount of smoke generated by the shearer is immensely different. When the shearer starts smoking, or when the shearer starts cutting less than its first case, it is time to change the shearer. If the shearer starts sparking or giving out smoke, then it is already too late. It is better to throw the instrument away immediately and take a new insert.
Okay.
Yeah, I think the most important thing is the tissue should be moist. So only if there
Yes.
is a water content in the tissues, the current will be able to pass through. Otherwise, it is going to stray. So that we have to keep in mind. I think that is one of the safety aspect which we need to follow in these. Ultimately, we have to understand these physics and then how it is going to, work on the tissues.
I
So
think there's, ma'am, there's one last question. How
yeah.
to avoid capacitated coupling through trocar while using monopolar? Using plastic can be helpful or what? Because we are not
Yes.
using metallic.
Yes, it can be helpful. If you use plastic, there is no question of capacitative coupling because plastic cannot get activated at all. So using plastic trocars, of course, and most of the times it does not even happen. So maybe it happens at a very high voltage, which we do not use.
Yes.
But for me, I have not seen much of capacitative coupling happen, or never seen it happen in a case actually. Only probably my understanding is if you use a very high voltage current, it will happen. But I use metallic trocars freely, and I use monopolar electrodes through the metallic trocars. I have never really had a case where capacitative coupling has touchwood caused any damage. But yes, if you use plastic trocar, then the whole thing of the capacitative coupling just goes out. Nothing will happen.
Yeah.
Ankit sir,
Uh,
now everyone wants to know what is your cautery settings.
Cautery settings. So, sir, I will tell cautery settings, but it will be brand specific.
Okay,
For the Allen cautery, they have levels between 1 to 5 of ligate and 1 to 5 of cut. I use minimum ligate, so L1, and maximum cut, so C5. So L1
okay,
C5, bipolar 40, monopolar 40.
okay.
So what is the time frame like when you have an accidental touch on the viscous, like the bowel?
Hmm.
When do you really take an action?
So even if there is an accidental touch, the action is immediate, madam. As you know, even if you touch the bipolar for a fraction of a second, you still get a white patch. Generally, what I do is by making mistakes over time again and again. Firstly, I sometimes ignored, then sometimes I had a problem, then sometimes I managed it. But now what I do is, if the bipolar so much even as touches and leaves a white mark, I take a Vicryl, take a stay suture over there, complete the surgery, and then come back to see whether or not really something is required to be done. If it is required, then I take a burying suture. So if it's on bladder, a burying suture that will bury the damaged area inside. Likewise on the bowel, another interrupted suture or something which will undermine the edge and it will push it inside, so that nothing happens usually at the end.
Yeah, that is very important. So when there is a blanching, we wait for some time and then proceed with the surgery and come back and see whether there is a resumption of the color, pink color. If blanch still persists, then it is safer to always take a bite. So that one thing we have to keep it in mind. Um, okay.
One more, that what is the specific use of monopolar which the bipolar can't do?
specific use of monopolar which bipolar can't do. Okay. Specific use of monopolar is if you do not want an instrument with two jaws, you want an instrument with only one tip, and you still want it to cut. This bipolar cannot do. Okay, so if you want fine cut, let's say you want to cut the vault, okay, and you want to cut in a straight line from one circumference to the other, but you don't want that the bipolar should have bites again and again and again, then that is the time you use monopolar. On pure cutting mode, the lateral spread of monopolar will be much less than bipolar. So if you use monopolar in pure cutting mode, it is almost as good as using a cold scissor only. So fine cut is the place where you can use monopolar, but instrument has to be good, new, generator has to be excellent. These two criteria have to be satisfied.
Yeah, very true. So thermal spread is very less with monopolar cutting. Yeah. So does wet tissue have more thermal spread? It is the other way.
Yes. So wet tissue, the more amount of moisture in the tissue, the more intracellular fluid. The more intracellular fluid, the more possibility for the current to go inside and vaporize that fluid. So if there is, so you know that when we check bipolar, suppose you give it to your staff and the bipolar is not working, and the bipolar staff takes a dry gauze and tries to check bipolar on that. Obviously, she will not have current flowing because the gauze is dry. But when you put betadine on that gauze and then you check it, immediately you find that the current is flowing again. So water or moisture is required for the current to flow. Similarly, that also explains concept of lateral spread, because once you have got tissue held between the two jaws and that tissue is coagulated, the coagulated tissue is now offering very high resistance to the flow of current. So current doesn't want to do that extra mehnat to go through that tissue anymore. It will start spreading laterally and then more laterally and more laterally, and that's how you start getting lateral spread. So moisture is a prerequisite for
Yeah.
current to flow.
Yes, it is mandatory. That's why you keep irrigating the tissue as you're cauterizing.
Exactly.
Yes.
There is another question. You cut vagina with the shearer or the monopolar?
Shearer, everything with
Okay.
shearer. Full
Okay.
case start to finish with shearer.
Okay. So I think
We'll go to the next lecture.
yeah.
Yes, yes.
Yeah,
With
sure, we
paucity
can
of the
take
time, we should move
Yes,
to the
sir.
next section.
Yeah,
Thank you, everyone. Thank you very much.
It was a very
Thank you,
nice
sir.
presentation and
Thank you.
yeah,
Nice presentation.
interactions. Yeah. So may I request now? Yeah, go ahead, Dr. Mohit.
Yeah, ma'am. The second generation energy sources like ultrasonic, advanced bipolar, laser, and plasma surgery. I would like to invite our chairperson, Dr. Prabha Desai, and speaker, Dr. Ashish Kale, sir. And Dr. Prabha Desai has many feathers in her other than the MS OBGY. She is a consultant gynec endoscopic surgeon and proprietor of LY Desai Memorial's first multi-speciality hospital, Karnataka. North Karnataka's first center to conduct IIG training course in gynec endoscopy and Rajiv Gandhi University fellowship in minimal invasive surgery. She's a life member of IMA, FOXY, IAG, ISAR, and GOGs. Two-time elected as a president of GOG. Award Golden Jubilee Award by Mumbai 2002 and 3 for the best thesis. IAG Excellence Skill Young Star Award in Minimal Invasive Surgery in Gynecology 2023. First best prize-based poster prize in KISAR 2019. Invited as faculty at the various national conference and been part of organizing team of several workshops and special interest of gynec endoscopy and urogynecology and optimizing free PEP smear camps at village level and creating awareness about the Save the Uterus. It is all yours, ma'am. Prabha, ma'am.
Thank you. Thank you, Dr. Mohil, for kind introduction. It's my prime privilege to introduce Dr. Ashish Kale sir, who is a director of Asha IVF Center and director of Asha Kiran Hospital, Pune. And he is right now at means he was treasurer of. He has worked in very much in very much in IG, Foxy, and ISAR. He's always in an executive committee member of IG, Also, worked as a treasurer in 2024 and 26 of IAG, and he was the committee chairperson for Family and Welfare Foxy 2023-25, secretary of POGS in 2022 to 23, founder Librarian Maharashtra Chapter IAG 2019 and 23, executive member Maharashtra Chapter 2018-23, and executive National ISA 2016 and 22, and he is recipients of very so many awards as a Legends of Gynecology by BOGS 2024, Foxy.
Yes, welcome, Dr. Ashish
Yeah,
Kale,
so
for your
many
lecture.
awards and these things are there. I welcome Dr. Ashish for his electrosurgical talk.
Thank you, madam.
Prabha, if you read his CV, it will take 2 hours.
Yeah,
Yeah.
really.
Only in 4 lines
I
he
was
has
not
put.
getting
Okay.
where to stop to read his CV.
Welcome, Ashish sir.
So thank
Welcome,
you.
Ashish.
At the outset, I am thankful to our president of IIG, Dr. Kalyan Barmade, Secretary Sujal Munshi, and the coordinator of this webinar, Dr. Mala Raj and Mohil Patel, for giving me this chance to talk and interact with you all. Today, after listening to the monopolar and bipolar, they had given me a chance to talk about the advanced bipolar, maybe a plasma energy source, and I will be little bit touching upon the lasers. Friends and my colleagues, when you're talking about anything related to electrosurgery, we need to understand every instrument and every energy source is a good and excellent. It depends upon how we are using it, and we should understand the principles of using it. So, what the previous speaker was talking about, the monopolar is excellent. It is not something which is causing a lateral spread. What is the idea behind all this webinar is to understand how we can use it, the instrument to it maximize efficacy so that the minimal complications will be gone through. So the evaluation of the like we are evolved from the many generations, the similarly the technology evolves. We never thought about using the mobile for our transactions of the monetary gains. We never thought about watching the movies on the mobile phones. Similarly, the electrosurgical principles has evolved from the monopolar to the bipolar to the tissue sensitizers, and now it is a bit the harmonic and the lasers. Why we need to understand its evaluation? Because we need to understand every precision of this particular energy sources has its own advantages as well as a particular mindset of using it. So the basics of the bipolar and the electrosurgically, they are already spoken by the previous speaker. I will not go into the details of it. We know the electric currents and the electric surgery is a totally different. Electrocautery and electrosurgical things are totally different. Electrocautery is being used for a different reasons, and that's why we get that when you switch on the plug and we get the current, it is because of the electrocautery and electrosurgicals. When we have two principles wherein the cutting and the coagulating current is being used in specific way, it is not something new that we have come up with. It is a 1926. It has been implemented into our surgical field, and now we are using the ultrasonic waves, or we are using the lasers, which is more precise and more able to have a precise cutting and the coagulation effectively. So he talked about the complications of the electrosurgery, the direct coupling and indirect coupling, and he also talked about the insulation failures, and that's why we need to have the what is the need of a second generation is because of we are going to use a higher current with the less voltage, less thermal spread, the impedance feedback and the endpoint feedback. We need to have the principally using the principles of grasping, then dissection, coagulation, and then transect. So, my friends, when we are talking about this particular energy sources and energy equipments, what we had, we need to working on the principles where there is a less thermal current, where there is an impedance that we don't want a charring, we want a dedication or a desiccation of the tissues, where the tissue itself gives an feedback that the desiccation has been completed, so that the excessive charring won't be taking place, and we need to have the tip of the instrument which can be used as a dissector as well as the coagulator. So coming down to the advanced bipolars, we will be talking about about a gyrus, we will be talking about a ligature, we will be talking about lasers and the ultrasonic scalpels. What is the all these things when we are going to talk about what is the common thing? The common thing in this all the advanced bipolars or advanced energy sources is to know what is the best tissue dissector and the coagulations. When we talk about the good surgeons only knows the anatomy is not the beneficial. We know to have when we do the surgery, it should be a bloodless surgery and it should be a prompt surgery in order to do a dissection properly in a proper plane. So ultrasonic device is a converts the ultrasonic energy into the mechanical energy. We know there is a lysis of the H bond, that is a hydroxy bonds, and the heat is a denaturation of the protein occurs, and then there is a separation of the tissues. Then there is always a problem that the harmonic what setting one should be using and what setting the usually causes a coagulation. My friends, when you are using a certain instrument, it has a jaw, it has a tip. So when you are using the jaw as for the coagulation for a higher time, it causes more of the coagulation. When you are using the tip, it used as a dissectors, and when you are using the tip usually causes the coagulation of the smaller capillaries, and we are using the as a jaw to grasp the tissue, it will cause the more of the coagulation. The what is the advantages of these particular devices? All of us are using the harmonic. It is not something new, so I will not tell you what to be best about it, but we should be knowing how to use it. It because it is all of us knows it causes the minimal thermal spread. It is causing a less tissue charring. We never seen there is a smoke coming after the harmonic use, but there is a sometimes you get that some of the tissue particles is coming on your camera head and causes a smothering effect. And this is because the principles of this harmonic is to cause a vibrational effect. These vibrations are more than a 5 lakhs or 550,000 oscillations, and these oscillations causes the coagulum formation, and this coagulation formation causes the tissue destruction. The disadvantage, it is definitely can be used for bigger vessels, but you need to understand what is the capacity of this particular instrument to cause the coagulation. The availability, they are claiming that now at the advanced ACE is coming up, which coagulate up to the 7 millimeter. But you need to have, there is a 3-step coagulation. You coagulate between the two and then you cut in the middle. But usually it is an operative dependency is there, and you need to have basically a learning curve for using the harmonic scalpel, and also the cost is an disadvantage for it. Okay, so coming down to the what are the advances of the bipolar? The bipolar comes in a two different ways. It comes as a gyrus, which is by Olympus, Ensil, and the ligature. I will go not into the details of it later on. The advanced bipolar is a electrogenerators are the available which sense the tissue impedance, automatically controls the current flowing from the adjacent voltage, and the current is been modified. Once the intended ceiling level is been reached, the auto signaling is given back to the surgeon. So we get that particular beep of the machine, and then you can able to complete it. This guards against the prolonged device activation and decrease the tissue charring, and it reduces the lateral spread current, which make these devices extremely safe while doing in the pelvic dissection. Coming down to the bipolar the gyrus, it is a plasma kinetic energy which can be used, and this is intermittent. There is a cooling of the tissue to prevent the thermal damage, and there is a less sticking. It acts on the two principles. It acts as a first is a vapor pulse coagulator, and second is a plasma kinetic cutting. The audible impedance is the endpoint of these indicators. The plasma kinetic energy to the tissue causes the vapor zone along it, and the current passes through it, and this vapor zone then collapses and causing the tissue sealing. The ensil is adjust the and as compared to the gyrus, the what is the ensil has? The ensil adjusts the energy according to the tissue impedance, and the smart electrode technique, that is there is a millions of the nanoparticles which has been formation of the there, and that causes a designation of the thermostatic switch. Each particle interrupts the current flow to the specific tissue, and when the temperature increases, it causes the coagulation to form. The less heat is required as the tissue volume reduces by the compression, because once the tissue is going to get compressed, it causes the reduction in the tissue volume, and this tissue volume then goes into the protein denaturation and renaturation, and this causes the healing of the sealing of the tissue to the level of the 7 millimeter, and it really decreases the lateral spread to the 1 millimeter. Coming down to the another advanced bipolar is a ligature. The ligature also works on the principle of the pressure and the energy. Once you closes the jaw of the ligature, it causes the pressure on the tissues. It causes the energy to go through between the two jaws. It causes the denaturation of the collagens and the elastin, and then there is a permanent sealing which occurs. If the hydrothermal causes the collagens crosses the links of the 60 to 90 degree. The cooling, after that there is a cooling, and then the wound gets the strand formation of the collagen strands, and it going to get this respect. When you see this ligature in between the two jaws, you can see in this particular figure, there is a native collagen. When the heat is going to get passed between the two jaws, there is a heat along with the pressure, which formation of the collagen tissues is going to get disrupted, and you get the first is a cutting effect. The nano coagulated the jaw. This is the new bipolar device by the same principles, where you have a curve as a Maryland jaw, and this is coming up with the same ligature as a technology. This jaws has a non-sticking particles, so the jaw is not going to have a stickiness when the completion of the coagulation is going formed. So the average sealing cycle is 2 to 4 seconds. The seal which can heal, which can stand through the 3 times the systolic pressure, and it can seal up to the 7 millimeter vessels. There is a impedance of the tissue. So the tissue once is going to get coagulation formation and the formation of the coagulum, the tissue impedance is going to get the signal to the device, and it will give this response that the coagulation is been formed, and then the cutting cycles continues. These are the different ligatures. You can use it for the open surgery as well as for the laparoscopic purpose. There are the specialty of the ligature beds. You can have the, as a previous speaker was talking about, if you have the smaller area to have the coagulation as well as the cutting, you can use the hook, you can use the bisect, you can use the Maryland, which is coming up in the next cycles. This is the jaw which has been modified. If you see the jaws of this, the jaws has two different styles. It has a 22.6 millimeter seal length, and the cutting length is of 21.8. Why it is a length which is less? Because once your coagulation is or completed, only the cutting will occurs to the 21 millimeter and less of the 0.6 microns of the millimeter which is left behind. So you have a good coagulation, and the cutting will be the lesser, so that the blood will not have the trickling effect, and you have the clean surgeries to go ahead. It comes in a different shaft. The shaft comes in a different length because it can be used for the bariatric purposes also, and you can have a 360-degree rotation with the bipolar as a this is a ligature. And now the next generation designs come up with the reusable. They are having said that you have the battery backups. You come up with the battery chargers. You can just apply this battery. Why it is important to have more generations of this? Because if you are coming up with the different instruments, the instruments come up with the cables, come up with the generators, and come up with the reusable instruments. But my friends, when you are using this kind of a generators, it comes with the longer cables. So usually it comes across the field. So they come up with the batteries. So you can just have a charging of the batteries, and you can just put it into the instrument, and you can use this as a transductor. Coming to the next, these are the usually you have the battery chargers. You can be easily used this, and this can go for a more than a 30 to 60 minutes. Once we come down to the what is the importance of all these thermal energy sources is a lateral energy spread and the burst pressure. What is the burst pressure? The burst pressure is when you are giving and coagulation of the particular tissue. When you release the jaw, the releasing of the jaw which causes the there is a spurting of the vessels. This has to be get total coagulation formation. So if you are thinking of the harmonic scalpel, the sealing time is 14 seconds as compared to the ligation, it is 10, and the insil is 19, because it requires a longer pressure effects for the insil to have the harmonic. It takes a little bit smaller, because it causes the pressure as well as the sealing, and it has the vibration mode, so it causes the sealing effect in a lesser time frame. When you're thinking of the burst pressure, the burst with the harmonic, it is a 204 millimeter of mercury. The ligature, it is 385, and with the insul, it's 255. What is the importance of it? When the burst pressure is on a higher side, it will cause a more effective coagulum formation and the easy for the dissector to happen. Similarly, if you're thinking the visibility of a smoke, the smoke is least been generated by the harmonic as compared to the insul. But nowadays, the ligature come up with requires a little bit lesser formation of the smoke. As an endoscopic surgery, what we want a clean field, we want a good vision, because if the yeah, smoking is there or charring is more, you require a haziness of the field, and that requires so again the CO2 to go off, and again the filling of the abdomen pressures, and that usually will not happen with the harmonic, or for that matter a ligature also. Coming down to the lasers again, to touch upon the few, we use a gynec lasers in a different setting. We use a lasers for the vaginal surgeries, vaginal rejuvenation, and also the vaginal hospitology. My friends, when we are using the laser in those particular instances, we don't require the penetration of the lasers. The lasers has its a beautiful way to handle. If you are going the micron levels in the depth of the penetration, it causes the activation of the tissue levels, and it causes the tissue by healing by more of the fibrosis. If you go a little bit superficial, though only there is a collagen modulation, and this the modulation occurs. The collagen modulation occurs is because of the formation of the rehealing and resurfacing, and that's why when you are using the any kind of a laser, whether it is a superficial like a vaginal aesthetic, we use it for the collagen tissue resurfacing. We are not using it for the cutting. But when we are using in the laparoscopically, the laparoscopic, where we have a precision of the cutting and the coagulation, usually the electric current ionizes the argon, and which facilitates the current flow. So where what the usually this lasers or the argon beam coagulator forms, this form the safe space where the current will flow in, and which causes the functions to go through. The laser, the precise application of the energy, it causes the less damage, as I mentioned. It has we use a different lasers. We use a CO2 lasers, argon, as well as the Nd:YAG lasers. The energy what we use is a first is a energy induced a molecular vibration and the thermal vibration, and that's where it's going to have the effect on. This is a diagrammatic representations where your laser is going to use. If you are using a Nd:YAG laser, the tissue penetration will be on a higher side. The CO2 and excimer users of these lasers will be a much more superficial, and this will cause a modulation of the collagen, and this what we are using in the gynecological aesthetic gynecology, and not in the laparoscopy. So here the laparoscopic surgery usually use CO2 lasers, and the argon lasers usually uses for the endometriosis surgery and maybe in the lymphadenectomy, where the blood vessels are much more in the near areas, or maybe a vital structures where we don't want it to get hurt or get damage to that vital structures, where you are using the CO2 lasers. This is the Nd:YAG lasers, how it is used. Nd:YAG lasers goes from the highly reflected, there is a mirror and there is a flash lamp, the pump source where the laser is been produced, and with the reflected mirrors, it is going to be reflective into a particular point where it is going to act on. So advantages of the lasers is a bloodless field is much more on a higher side. the excellent hemostasis can be achieved, and the point of coagulation will be excellent healing, allow the precise microsurgery. So the endometriosis where the bloody field is usually been there, because there are the microvasculatures, and this causes the field much more weight and much more bloody. In that particular conditions, you can use the lasers. It allows the less post-operative pain and the edema. It decreases the infection rate, and the outpatient procedure is can be done with this particular thing. I think I'm done with my presentations. I'm happy to answer more of the questions rather, because this is more like a theoretical point. So I will more happy to address the practical ones. Thank you. Thank you for giving me opportunity.
Thank you, Dr. Ashish sir, for your crisp presentation.
So, Dr. Ashish, what would be your favorite energy source if you are asked to take only one among all the?
Only one, then I will be going with the sharer nowadays, because it's for India, it is much more lesser of the cost. Precision is been there now, because we are using it quite a lot of cases. Secondly, it is better that it is not having the sharper end. It has a blunt end, so the dissection in the vital tissue, like a fingers, it uses a better way of tissue dissectors.
Yeah, very true. So all these advanced energy sources are very nice. I mean, but then unless and until we are comfortable with the monopolar and bipolar, we cannot perform any surgery. So that is mandatory that we should be very familiar and comfortable in using them. So in among harmonic and advanced bipolar, which do you prefer?
The harmonic I should be using more, because it's a good dissector. And if you are using the tip, I think it is better to go into the vital structures, or maybe in the deeper in the pelvis. Usually the champagne effect, what we can visualize with the harmonic, cannot be able to replicate with the advanced bipolar, because advanced bipolar can be used taking the uterosacrals, or maybe vital structures like IP ligaments, where we don't want a reverse bleeding. In that particularly where the volume of the tissue is a higher side, where you just make the volume of the tissue lower by doing the application of this ligature, or maybe a advanced bipolar, make it into the pressure effect and make that into thinner things to go. The lateral spread is again the loss. But if you ask me which is the better, I think that harmonic has a better visibility and better into the tissue duct.
Yeah, so ultimately it all depends on what kind of surgery you're doing and what dissection you're going to perform. And more of a dissection, I think we would prefer with a harmonic. And when we need more of a, vessel sealing effect, then probably advanced bipolar would have been a better choice. So this burst pressure, so which do you think is higher, and which has got a better burst pressure? The harmonic
burst pressure with the harmonic is on a higher side as compared to the both the ligature and the gyrus.
Yeah,
because what you actually, it is the amount of the time you are just keeping it, and you are releasing it. The burst will gives a smaller burst, will have that harmonic will gives a more oscillation effect, and that will cause a coagulum formation much more higher as compared to the longer effect of the ligature, because you have to ligature to apply for a certain seconds of time, 2 to 4 seconds, and then it will cause that coagulum formation.
Yeah, so they bring the intima contact. So basically, they say like for a harmonic, they have also done a study where they found that the burst pressure is almost 3 times the systolic pressure. So in that way, I think it has got a better burst pressure compared to that of the vessel sealers. But then generally, we like when it comes to vessel sealing, we generally go with an advanced bipolar, either the ligature or NSAID. But then the studies are showing something different as well.
You use that 3 methods, like when you coagulate first, and then you use a harmonic tip to dissect it out.
So it is basically how you use the energy sources is what matters, no? Like,
Ashish sir.
So
nowadays there is an 1100 probe, so it can seal up to the 7 mm right now.
Yes.
Yeah, and some of the questions are there. Is plane identification is better with the harmonic than the shearer?
Pardon me?
Is plane identification better with the harmonic than shearer?
See, it depends upon your tip of the instrument. because the
Okay.
ligature don't have that much of a nicer tip. The nicer tip is more sharp. If you are having a, like if you see this neo generator harmonic, it has a curved tip and it is a more of a solid tip, and the blunt tip is there. Not like a previously your harmonic has a only a blunt tip. It has a, nowadays it has like a beak. So if you have a, like a beak of the any of the bird, it causes some more tissue dissector.
Yeah.
Yeah, it's the same what he
Mm.
was discussing. It is a thousand eye, the probe of harmonic, which is more useful for dissecting in deeper tissues and in special cases of endometriosis,
Yes.
where you want to go in deep into the pelvis and around the ureters. This very narrow tip and a long tip will helpful. So that is this thing. And one question was there actually, whether for using the IP ligament, will you prefer the harmonic or your regular bipolar?
I think
The
I will
question
be
is
using a regular bipolar for the IP ligament, because
okay.
IP ligament usually the branches are directly from the main arteries, and it is always precise to have a good coagulation. And whenever I'm doing a coagulation of the IP ligament, I will not stretch it out. I will loosen the IP ligament and then I will coagulate, and then I will do a dissection of the IP. Because once it goes to retract, it will go into the retroperitoneal very easily.
Yes, yes. Thank you, sir. It's a very nice tip.
In fact, lateral spread also
So
very minimal with ultrasonic, no? So compared to that of the other advanced bipolar. So I think when we are working on the vital organs and doing a retroperitoneal dissection, that would be a better bet. So I think that was an excellent presentation, Dr. Ashish. Very
Thank you, Dr. Mala. It's been
clear,
an honor
yeah, it was
to have
very
on the
clear.
IIG platform.
Yeah. So
very good practical tips also.
yeah.
Thank you, sir.
There is one question where someone has asked, like, if there are multiple injuries, bladder, bowel, ureteric, and all, will you still continue doing a laparoscopy or you will resort to laparotomy?
To answer the previously, Dr. Sanket was talking about. See, my
Mm.
friends, when we are talking of the any energy sources, even if there is a blanching or there is a injury, the blanching or even if you are touching with the, supposedly inadvertently you touch the any vital organ, the electric current and causes a wide necrosis. And usually this whitening of the tissue, and then it causes a ischemia of the tissue, and then the necrosis, usually it accounts for 5 to 7 days. Like not like a with the scissor. If I cut the vital structure with the scissor, it will cause a implementation of that complication immediately post operative period. But if you're using any of the energy sources, there is a delayed complication which will come back to you. So patient with the rigidity of the bowel come down to you after 5 to 7 days if you are touched the bowel with the harmonic or maybe inadvertently injuring with the current. So when there is a current we are causing any tissue injury, it is apt that you should be observing that tissue. What Sanket was asking about, to get the wider excision of that part and then resuture rather than just burying that tissue. Because just burying that tissue, when there is a whitening of this particular part, it will cause a necrosis of the wider area.
Yeah,
So
that is.
later on, you will have the complications even if you bury that. So it
Mhm.
is better to use a wide excision and then closure of these particular defects.
Yeah, so here I think they want to know whether you will proceed with laparoscopy or laparotomy. I think it all depends upon the expertise. If you're able to tackle it laparoscopically, that would be the best option. If you feel that you need some help with laparotomy, then whichever is suiting you the best, you should go ahead. I think that is the key. And then I think we will end with this, Dr. Ashish. That was an
Yeah.
excellent presentation.
See, one thing, Dr. Mala, actually, that is there is always this thing misconcept that harmonic has got a lateral spread less than the bipolar. Actually, harmonic also has got a very
Yes.
much lateral spread, and its tip gets very much heated when you use it. So,
Yeah.
as we use the other energy sources, we have to be very careful about the harmonic also.
Yes.
Very true.
Yeah.
Even
Hello.
just, they say like even a 10-second of touch on the bowel can
Yeah.
significant amount of injury. So to be quite careful about harmonic. And harmonic, the lateral spread is just 1 mm. So and when they
Yeah.
compare harmonic and the advanced bipolar, it is relatively less with harmonic compared to advanced bipolar. So, and if you compare with other energy sources also, it is relatively less compared to the monopolar
Yes.
and bipolar as well. Okay. So I think we will end with this. Thank you so much, Dr.
Yeah.
And thank you so much, Dr. Prabha Desai, for joining.
Yeah. Thank you, ma'am.
And
Thank you.
on to we move on to the next presentation, and the most important one and the latest in kid in the block. In fact, we can say the third generation energy sources. So long we've been only seeing energy sources being used mainly for hemostasis. We wanted coagulation and we wanted cutting, so we were using the energy sources. Now we are in the era where we can use energy source to even to shrink a tissue or to shrink an organ. To highlight on this, like how exactly these energy sources are working to shrink an organ or a tissue, we have with us Dr. Xiaoming Gong from China. So to introduce the speaker, we have Dr. Krishna Kumar sir with us. Sir, welcome, sir. So can I have Dr. Krishna Kumar sir's CV, please? So as everyone knows, Dr. Sahiti, please share Dr. Krishna Kumar sir's CV. So as everyone knows, Dr. Krishna Kumar sir is our past president of IAG, and in fact, he is very, very fondly called as a permanent president of IAG because he is so very involved with IAG, and he's a great advisor for everyone. And then, in fact, his cadaveric courses in IAG is a super hit, and it is most welcome course by everyone, and people tremendously benefit out of these courses which are being conducted by Dr. Krishna Kumar sir in Ramaya Medical College. And then we have many courses lined up by sir for the next cadaver sessions. So we'll request Dr. Krishna Kumar sir to introduce our speakers. Yeah, Dr. Gong CV.
Thank you, Mala, for the introduction, and I must congratulate the present IAG team for having this wonderful webinar on one of the most important aspects of our modern day surgery. And I'm sure that the speakers are doing excellent and everybody's benefited. And as you rightly said, the newest kid on the block, which for us gynecologists is relatively new. We all are very well averse with all the harmonic and other sources, but microablation is something new to most of us, though we have been reading as to the advantages of the same in necrosing the tissues or tumors, basically. And I'm sure Dr. Gong is a leader in this, and he will be giving a wonderful overview of the microwave ablation technique and what is the exact physics behind it and the main uses of it. Welcome, Dr. Gong, and thanks for joining us here for the IAG webinar.
Thank you. Thank you, colleagues from India. I'm Dr. Xiaoming Feng. Let me share my slide. Okay. Hello. Okay. Okay. Okay, got it. So today my topic is about microwave. I don't think that is according to your the webinar. It's like a certain generation. I do endoscopic surgery as well, but right now I do more and more ablation therapy. I use microwave and also radio frequency. But right now, 80% of my ablation was done with the microwave. So I use this differently as ablation energy. So for the basic knowledge of the microwave it works just as your microwave oven in your kitchen. So this is our device. We have an antenna and also a generator. This is a generator. This is the one device I used very often in my practice. This is antenna. This antenna has a different length from 15 centimeter to 30 centimeter. We can do it abdominally or vaginally. With this generator, it can produce energy to cause a necrosis of the tissue. So we use this device to do the ablation therapy. Right now, this is another device. It's similar. There's also a generator and also has an antenna to produce this necrosis zone. So it's different with our traditional monopolar or bipolar device. We use that device to coagulate the vessel and to cut the tissue. With this device, we produce the energy to cut the necrosis of the tissue. For our gynecology benign disease, especially the uterine fibers and adenomyosis, we do differently with lung cancer or liver cancer because all these diseases are hormone related. So we can wait for the patient till the menopause, and the patient can get well. One aim of the treatment is to shrink the lesion and to relieve the patient's symptom. So compared to the traditional resection therapy, it has a better because it has a very tiny. This one usually is 14 to 16 G, so it's very tiny and it can cause a very small wound on the abdominal wall and has less bleeding compared to our traditional open surgery and laparoscopic surgery. So this is the advantage of our treatment. Right now, when we do the microwave ablation, we can do it percutaneously, or we can do it just cervically. We can also put it into the uterine cavity and monitor with abdominal ultrasound. And we also can do with a laparoscopic surveillance. And also, we have a specially designed antenna to do the endometrial ablation. So this is the animation I made for our patients. Usually, it was guided by the ultrasound probe. So with the ultrasound probe, we can insert this antenna directly into the lesion, and with the movement of this antenna, we can gradually ablate this tumor, and finally, we can achieve a very high ablation rate. Compared to the like liver cancer and lung cancer or thyroid cancer, it's different because when we do the ablation, we have to protect the bowel, sometimes we need to protect the endometrium. So when we do this kind of benign ablation, we use to restrict the energy inside the tumor. So we cannot achieve 100% of the ablation. It's different with the malignancy tumor. So if you have a thyroid cancer, you have to ablate the cancer 100%. So for us, we do the ablation for the adenomyosis and uterine fibers. Usually, we only treat those symptomatic adenomyosis. For the uterine fibers, we can also treat those symptomatic. And for those, especially for those patients with a fertility requirement, we treat this type 3 to type 5 myoma. When the myoma is greater than 5 centimeter. If this myoma is type 0 to type 2, I prefer to use the hysteroscopic resection to do the resection instead of the ablation. Sometimes when we use this microwave energy, it will cause the unnecessary damage to the endometrium. So I want to avoid this damage to the endometrium, especially when patient want to have a fertility result. So if the lesion is greater than 2, we can ablate it. But that doesn't mean that we need to do every myoma. I always said that if you don't have symptom, you don't need to treat this kind of fibers. unless if you have a huge one, you can ablate those small fibers at the same time. When we do the ablation evaluation, the most important thing for us is want to check the ultrasound route. So right now, majority of my cases are done with the ultrasound guide. It's not. I know that some doctors in India they start to do the microwave ablation, but many of them they still do the laparoscopic guide. Compared to the laparoscopic guide, the ultrasound guide has a much less damage to the patient. So I prefer everybody to know this ultrasound guide, this procedure. Okay. So this just want to show how it works. Usually we'll put this antenna directly into the tissue, and we monitor this area with the ultrasound. With this video, I just want to show you that how it works, because it also has a water circulation inside this antenna, can bring down the energy along this antenna. So the tip is very hot. So the tip will cause the damage to the tumor tissue, but the puncture route is relatively safe. Sometimes we will do the biopsy, especially myeloma. We will do the biopsy before the treatment. We don't do biopsy for the adenomyosis. Usually, so in our practice, we usually will put the patient in a laparoscopic position and we put a urine catheter. Our assistant will help us to use our hand or use his hand or a manipulator to push the uterus upward. This is sometimes we put some normal saline into the abdominal cavity to protect the bowel. This is how we do the ablation. So with this abdominal ultrasound probe, we can guide this antenna. We can guide this antenna. Okay, maybe next one. Okay, this one, you can see it more clearly with ultrasound image. So this patient has multiple fibers. This is enhanced ultrasound. With the enhanced ultrasound before the treatment, you can see the fibers will have blood supply inside the fibers. And usually we'll put the antenna in this posterior one first, and with gradually we move this antenna to the superficial one. So when we see this the white reaction, it means that was ablated. I started with HIFU about 15 or 16 years ago in China. But when I have the microwave, I quit HIFU because compared to the microwave, it works. The HIFU compared to HIFU, microwave works much faster, and also the device is very cheap. So that's the advantage of why I quit the HIFU and try to use this method. And also it can combine with hysteroscopic surgery and I can do the biopsy together. So right now I don't do the seldom I choose to do the MR guide focused ultrasound. I quit HIFU, but I do a lot of the microwave. So after ablation, we repeat this enhanced ultrasound. We can see this dark area is we call the non-perfusion area. Also, we can measure this this volume. We get NPV rate, non-perfusion rate. So this is the MRI after the treatment. We can see this dark the necrosis area. So this is another case we do for the adenomyosis. This patient is she had a posterior wall adenomyosis. And let's see, the results is neither. So we put this antenna into the posterior wall. Compared to the fibers, it is relatively harder because you cannot see the capsule of the magma. Now you can see this white reaction on the tip. If you do HIFU before, you will be very happy to see this white HIFU area because it worked very fast. Sometimes, in some fibers, we can wait for a very long time to see this high echo reaction for HIFU. After the treatment, we can also see this non-perfusion area. So we repeated the MI after the microwave ablation. We can see this dark area. This is another case, diffuse adenomyosis. We can ablate the adenomyosis lesion and endometrium as well. So after the treatment, we can leave only a very tiny hole on her abdominal wall. Now we also do the vaginal approach or through the uterine cavity. This one is patient is posterior or posterior. She had a posterior the lesion, but it's very hard to get to the abdominal wall. So we put this antenna through the uterine cavity, and with the abdominal ultrasound monitor, we can put this antenna directly into this lesion, and we can ablate the lesion. So that's the second route. We can feel the bladder. We can monitor the procedure. The third route is we do the transcervical the route. So usually, especially for this lesion close to the cervix or in the posterior wall, can get a better image. So we use a longer antenna, 25 to 30 centimeter, and it was guided through the ultrasound guide. And it's relatively easy to learn. So if you have a good ultrasound machine, you are good at ultrasound, you can start this procedure very easily because you can put this needle, you can see it, you can play it. But I just want to mention about if you have a very big lesion, it's still good to do the abdominal way. Otherwise, it will be not too easy to see a very large lesion. So this is a lesion. We do the ablation. This is the vaginal ultrasound guide, prop guide, the antenna directly into the lesion. So this procedure is very easy to learn. So if you have the good ultrasound machine and you have this device, you can learn to do it very quickly. This is another case. We do the multiple fibers. We treat the fibers both abdominal wall. This big one anteriorly and the posterior through the vaginal approach. So for those patients have fertility requirement, we need to do the endometrial protection. We have some methods. We use some water or some gel to isolate the endometrium, and also we put the folic acid into the uterine cavity to irrigate. Also, we will always do the hysteroscopic exam before the ablation and after the ablation to make sure the individual is well protected. As I tell you before, that we prefer to treat with those type 0 to type 2 myeloma or lesion with a histoscopic resection. So we can use this energy device, this ablation together with the histoscopic methods. So it's a better way. So I think that if you use the ablation therapy, sometimes you will cause damage to the animation. This is a multiple center. We have some data regarding for its effectiveness and safety. Usually after the treatment, the volume will gradually shrink. So in 6 months, about 60 to 80% of the reduction of the volume. For the adenomyosis, especially for like a very very small lesion, but the patient had very severe pain. Like this patient, she had a very small lesion, but she had a VS score 10. So only 5 minutes ablation, we can finish her pain. Even for 4 years, no pain afterward. So if you do this laparoscopically, you know it will take about an hour to do to open this the uterine wall and to find this lesion and resect it and then you suture it. At least like a 1 hour surgery. Patient have very a reaction to the surgery. But after this very tiny ablation procedure, she can recover well. So that's our data regarding for the adenomyosis. Usually after the percutaneous ablation, about half of the patient have no pain after the treatment, and about 10% of patient will have hysterectomy after in 2 years. So that's our data. It's a good procedure and it's effective for adenomyosis treatment. For those fertility patients, we need to especially, I think that's really important to you know where to ablate it. Just like you know when you do this laparoscopic surgery, you know where to stop and where to resect it. So usually our experience we need to leave about 5 to 10 millimeter away from the serosa and away from the endometrium, especially just like this, for her posterior wall. If the patient don't have the fertility design, so we can ablate the endometrium. If we do it percutaneously, we achieve this kind of the result. If we do laparoscopic, we can get a higher MPV rate. So for the diffuse adenomyosis, it's more difficult to get a good result because this is not too easy to ablate them all. If the patient don't have the fertility design, we can ablate them all. So this is just I want to show how we protect the endometrium with irrigation. I want to show a very interesting case. I just want to show you the effectiveness of the microwave. This patient, she had the multiple IVF failure, and she also had 21 weeks of miscarriage. And finally, she had open surgery in year 2018. And after 2 years, she
Your voice is lost, Dr. Gong. Dr. Gong, excuse us, you are not audible.
Yeah, we are not able to hear you, Dr. Gong. So,
Dr. Gong, we are not able to hear you.
Check your microphone. By mistake, it has got put off. I think it's got disconnected.
Yeah,
Yeah.
internet.
Right. Now, of course,
He's
there's
almost through, sir.
yeah. No. There's something, of course, interesting. We all have heard about and read about microwave ablations and RFI ablation, but we in India.
Hello?
Hello?
Have you come back?
Hello? I'm back?
Yeah.
Yeah.
Sir, your voice is not very clear.
So, sorry.
Yeah.
Okay. Did you hear me before this?
Yeah, we can
Yes.
now
Yes.
only, but then can you share your presentation again?
Which one? Which one? This one?
No,
Yeah, your
we can't-
presentation is lost.
Your screen,
Yeah.
The last one?
It's back.
This one?
Yes.
Oh, yeah,
okay.
yeah.
So-
Clear, yeah.
Okay.
Yeah.
I will. Okay. This is a very interesting case. I just want to show how we treat this patient with RVF failure patient. She had a recurrent RVF failure and also have a 21 weeks miscarriage. Finally, she had open surgery in year 2018, and after this, she was required to have 2 years of this void of the another IVF cycle. So after 2 years, she had a relapse of the posterior wall adenomyosis. So we can see here she had a 7 centimeter of the lesion. So she don't want to do another open surgery, and she was referred to me, and we tried to do ablation for her. So after the ablation, we can see this lesion was ablated. After that, she got a GNIH analog for 4 months, and finally she had a successful IVF, and she had a cesarean section at 33 weeks. So this patient is our very beginning cases to do the for those patients have IVF failure and for the adenomyosis. So in this case, we can see compared to the open surgery, it's a very good method, and we can avoid open surgery or even laparoscopic adenomyomectomy for those kind of patients. So we can choose to do the ablation for those patients instead of to do resection. You can achieve, although it's a very small number. After that, we have some cases get pregnant. We need more data, more research for this procedure. But I think that it gives us a very promising these new methods for those pregnant for those infertility patients. So the last route is we can do another way to do a laparoscopic assisted microwave ablation. We choose to do this kind of ablation because some of the patients we will do that percutaneously or vaginally. We cannot achieve a higher percentage of the MBV rate. So with laparoscopic view, we can get a higher non-perfusion volume. So we choose this method for adenomyosis patient. We don't do this kind of procedure for fibrous patients because compared to the percutaneous method, it can also has a more traumatic for the patients. So this procedure is usually is guided by the laparoscopic surgery. So I think that for most doctors, this procedure is simple. But I just want to mention it's not just simple. Sometimes we still can get some complications. The only bowel injury for me in so many years for microwave ablation was occurred in this procedure, in laparoscopic procedure. When you have a big adenomyosis, be careful. You cannot see if you cannot see the tip. You have to monitor it. Okay. So after ablation, we can achieve a higher MPV rate compared to the vaginal approach or the percutaneous approach. And also, as I mentioned before, I prefer to do the resection for type 2 to type 0 to type 2 fibroids, and try to ablate those type 5, type 3 to type 7 fibroids with ablation. And also, we can do the in vitro checkup with a histoscopic the method. The last thing I want to mention is we also have this in vitro probe. We can do the ablation just like this radio frequency. I don't know if you know this Novo Assure. If you know Novo Assure, then this method is similar. It can destroy the endometrium. Especially for those patients don't have the fertility requirement, it can achieve amenorrhea or can improve her hemoglobin level after treatment. But I just want to remind you that with combined procedure, especially you do the individual ablation with lesion ablation with the microwave, has a higher infection rate. So our data regarding for the infection rate is about 13%. But after the treatment, this dysmenorrhea and menorrhagia is improved. Also, we can do ablation for those cesarean scar endometriosis. It's very simple. You just need to look at where the lesion is and what guided with the probe. You put this antenna into this lesion, and you can ablate the lesion easily. So I think that this is a very new method. I call this new method is after our laparoscopic surgery and histoscopic surgery. It's our next generation of the surgery. So I think that it's a very promising method. Not only just for our gynecologists, but also like for the surgeon, for general surgeon, for other specialty, subspecialty. It's a very good method. Lastly, want to mention that all these methods can has some complications, like a bleeding, infection, skin burn, bowel injury, pain, and watery discharge. One specific one, although sometimes because due to this microwave antenna, it can cause broken, or the tip was left in the body, and it was also a method. This is bleeding with subcutaneous hematoma. Infection, this is I just mentioned that the only bowel injury we had in this case because she had a adhesion and had a big small moderate uterus, and we cannot see it because of complication. So I think that ablation therapy is just like endoscopy surgery. It's a knife. You cannot see, but you need to see with ultrasound. Okay. We will have our ablation gynecology ablation workshop in Shanghai this September, right after APEC meeting. So if you want to learn this technique, we will do the lecture and the live demonstration in Shanghai in this workshop. Hopefully, you can join it. Thank you for your attention.
Thank you, Dr. Gong. Something very, very interesting and new to most of us here. Of course, there will be a lot of questions and discussions. I'm sure you're ready for that. But my question to you will be, you did mention that type 4 to type 1 fibroid you will manage hysteroscopically better. But for all of the symptomatic fibroid or adenomyosis, you would first prefer this microwave in today's scenario, or you will opt for laparoscopy and keep this only for some selected cases?
For adenomyosis, I always will try those marina or some digest first. If this conservative method failed, I will prefer to do the ablation or the hysterectomy. Also, we do a lot of vaginal hysterectomy. I don't mind, for the every gynecologist, you need to know every method, so it gives the best option for the patients.
Perfectly said.
Does it work well for the global adenomyosis also, the diffuse adenomyosis, or only for the focal ones?
It works. It depends on how you want to treat it. Because if the patient don't have the fertility, then it's simple. It's simple. But as my data show that if you have a very diffuse one, and it's more difficult to do the treatment with a diffuse one. If it's localized, especially only the posterior wall, right now I do more and more laparoscopic guided ablation, but only for the adenomyosis. For the fibers, I will prefer not to do the laparoscopically.
So have you encountered any kind of an post-operative necrosis in these patients after the procedure, and they have complained severe pain, and you had ended up doing a hysterectomy also?
Not pain, but only the one thing, especially you do the combined procedure, especially like hysteroscopic resection with endometrial ablation, the infection rate is relatively high. We have one patient got hysterectomy because of the infection, not well controlled. So for the pain, usually after the treatment, the pain will last for 4 to 6 hours. So during this the period, you will give the painkiller, and we will keep the patient in the hospital for 1 day. So usually after the 1 day, it's pretty okay. Just the oral painkiller is fine.
Okay.
These ablation, are you able to control the depth of ablation or the zone of ablation? Because you did mention that in patients wanting fertility, you will try to be away from the endometrium and also away from the serosa. How can that be managed? Because do you have the control over the zone of ablation?
Yeah, that's experience. The with the microwave, it's different with HIFU. We do with HIFU in the past. Sometimes you hit the lesion, but you didn't see the white reaction. But it doesn't mean that the energy is not reached to that point. So with a higher energy with microwave, you see the white reaction, that's the energy goes. So you try to avoid the white high echo reaction goes to the endometrium, goes too close to the serosa. So my experience, I want to keep 5 to 10 millimeter away from serosa, away from the endometrium, so you can just restrict your energy necrosis area zone in this small in this mammalian. So if you got a very small posterior wall or the lesion wall, like if you have the adenomyosis, usually I would treat the adenomyosis for the fertility patient unless the posterior wall or the anterior wall is greater than 4 centimeter. If it's less than 4 centimeter, I prefer not to do. Otherwise, this necrosis area is too narrow. So that's my personal experience.
So how long it takes for you to see the visual effect of the shrinkage of the tissues? Do you see it immediately during the procedure, or it takes some time for you to see the reduction in the volume?
Yeah, usually right after the ablation, we can see we checked with the enhanced ultrasound. We can see this non-perfusion area, and with the MRI, enhanced MRI, we can see this dark area. Usually, this dark area is a necrosis area, will shrink gradually. gradually. So in our data, that after 6 months, the volume will shrink by 60 to 80%.
So it takes 6 months for it to shrink.
Yeah.
No. It will shrink gradually. So you wait for 1 year, you're getting
Maximum
smaller.
effect.
The
Yeah,
infection
maximum
rate
effect
you,
we will get after 6 months.
infection rate you mentioned is
That's the-
quite high, 13%. So was there a case of
Yeah.
abscess
Well,
formation?
if you
Necrostate? Is there abscess formation in the necrosed area? Then how do you tackle?
Usually patient will have like abdominal pain and a fever. So you need to give her check the CBC and give her antibiotics. And sometimes, in some rare cases, we need to do DNC.
See, after healing of the your microablated area, but if the patient becomes pregnant, anything on the uterine, any difference you will find in pregnant uterus expansion or anything?
I know that most of you will worry about the uterine rupture rate, right?
Okay.
I would tell you that I would tell you that after ablation not only is not ablation is a concept, so it includes HIFU, it will include MR guide focus ultrasound, it includes microwave and the radio frequency. At each energy, if you destroy too much normal tissue, you will cause uterine rupture. I will show you, maybe if you have interest, I will show you one case with a HIFU. That's a patient got uterine rupture after the treatment because the patient was reported by the literature. I will show you this data. Maybe you will you want to see this. Let me show some of the. As my sorry, let me show this my slide. Complications. Okay. No complications. Okay, so I want to show one of this case. This is a HIFU patient. After the treatment, we can see this area was getting dark, was damaged by the energy. So this is another case caused by the damage to the HIFU because HIFU don't have the very precise image for this ablation zone. So it will sometimes cause unnecessary. So this case, she had she using rupture after the HIFU. You can see what's her problem is that is not due to this necrosis tissue because the normal uterine zone was ablated. So no normal zone in her anterior wall. So in
Not able to see the video, Dr.
Not able to see, yeah.
Video.
It's not a video. It's not a video. It's just a slide.
Okay, right.
The slide also we are not able to see.
It's a plain.
You can see it.
It's an empty slide. Yeah.
Okay, we'll try to see. You want to show it again? Can you see it now?
Not yeah,
Can you see
right
it?
now. Yeah, we can see now.
We can see now.
So I will show you that this case she had a uterine rupture because the energy goes too far away from it damaged the anterior wall. So after the ablation, she got pregnant, and that's how many weeks she had a uterine rupture. at 38 weeks of gestational age. So I would want to explain that the necrosis is okay unless you damage the too much tissue. I will show you a very interesting case. Just want to show some of my patients had pregnancy right after the treatment. Want to show one of the MI image. So usually after the, I don't know if you can see this is my MI.
No, we are not able to see your slides.
Okay. This is MI image. Can you see this one?
Yes.
Yeah.
Okay. So, this is a fiber patient, and when she want to get pregnant, she had a 7 centimeter of myoma. So we ablate this myoma, but usually we need to leave this 2 millimeter. This is myoma. So we still got some tissue left. This is endometrium, and this is myometrium. We protect this myometrium well. So right after the treatment, we ask the patient get pregnancy in her second month. She gets pregnant on her this is March, and she get pregnancy on May, and the next year in March she had a normal delivery. So I just want to mention you need to restrict this energy inside this myoma or inside this adenomyosis. Otherwise, you cause complication.
Thank you.
Thank you so much, sir.
Thank you.
It was a wonderful demonstration. It was the latest technology and a good eye opener for us also to know a new technological energy source. And so, Krishna Kumar sir, would you like to add something?
Sir, will you do under anesthesia or is this procedure will be done under anesthesia?
I always do with regional anesthesia or general anesthesia.
Okay.
In China, some doctors they do with a local. I don't like to do with local because you still feel pain during the procedure.
So, how long does it take for the fibroids to recur after the procedure? Because it recur right after the procedure.
Recurrence.
Oh, okay. So it's different. It's different with laparoscopic resection. So with the definition of the recurrence, after the treatment, you look at the image, the ultrasound image, you see another fibroids. You call this a recurrence. But after ablation, you check with the ultrasound. Even I'll just show you the dark area. You cannot tell this dark area from the normal ultrasound. So after the treatment, you can still see a 7 centimeter myoma there. It only shrink a little bit after, as I told you, in 6 months, it will shrink. The reduction of the volume is about 60 to 80%. So you cannot tell that it's a recurrence. Usually, I don't want to use this word of recurrence after the treatment. I would prefer to use another word, the secondary surgery, how the chance of the secondary surgery. So that's my concept. You don't use the recurrence. If you see this myoma there, you call it a recurrence, then it's 100% of recurrence.
Yeah, so it is only the persistent of the myoma, only that there is a volume reduction. Yeah, right. Fine. So maybe for a huge myoma, if you feel like you want to reduce the volume and then go ahead with a myomectomy, then this would be an option. Is that so?
No.
Don't do that.
No.
All our laparoscopic surgeons, like where we feel that it is much better to give a complete clearance and remove a myoma rather than, keeping some amount. What you're saying is a residual tissue, no? The residual myoma is going to be there even after the procedure. So that is the only thing which we have
Why?
to really think whether we should be able to
So,
take.
after microablation, how will be the tissue reduction, the process? It might be first necrosis, liquefaction, and then fibrosis.
Usually after several months, you do if you do another like
Suppose if you do
sometimes
pathological
yeah.
study after
I want to
microablation, yeah. So after
I
few
will,
days,
yeah, I will tell you this story that we do many of the hysteroscopy right now for some very difficult myoma like 7 to 9 centimeter of the myoma. We cannot do the hysteroscopy in the beginning, so
yeah,
sometimes we do two steps. One step is to the ablation, and after 3 to 6 months, we do second step of the because after the ablation and the gene analog, so usually the myoma will shrink in size, and it's possible to do the second step, the hysteroscopy resection. So in that case, usually we can see this tissue is becoming very soft. It's a necrosis. It's a necrotic tissue. So it's very
yeah,
soft. If you have a shaver, it's very easy to remove with shaver at that time. So that's our method to do this kind of procedure. We are trying to do some difficult cases for hysteroscopy. So in two steps, one step the ablation, second step hysteroscopy.
Yeah, thank you so much, Dr. Gong. I think for want of time, we will close this session. So it was a wonderful
thank you.
and it was a good eye opener for us to all know the new
Yeah.
technology which has really come in. Thank you so much for your knowledge and also your inputs and your valuable time for spending with us. So with this, we come to the end of the first episode of Trocar Scope and the Trocar series. So can I have our Honorary Secretary, Dr. Sujal, to do the vote of thanks, please?
So I would like to congratulate the team, especially Dr. Malakan and Mohil Bhai for perfect coordination of a very informative session. On behalf of organizing team, I thank all the speakers, Dr. Zioma Ligong, Dr. Ashish Kale, and Dr. Sanket Pisaj for very informative lecture. All chairpersons for being here and sharing the knowledge, and the last not but the least, the whole audience for being there in very large number, making us feel very good. So thank you very much. It is just a beginning, and we ensure that in coming few days we will have much more informative sessions. They will follow. Thank you very much.
Yeah. Thank you so much.
Thank you so much.
Thank you so much, IAGE, Dr. Kalyan Bamde, Dr. Sujal Munshi, for giving us this wonderful opportunity to organize this webinar. Thank you, Dr. Mohil, for cooperating and making sure everything is in order, and also for taking forward this webinar. So I'll also like to thank all our delegates who have attended in large numbers, and so meet you again the next first Friday of next month with another an interesting series of Scope and Troca. So thank you so much, IAG, and thank you, Shield Pharma, for being our academic partner. Thank you so much, Sahiti, for a very seamless transmission.
Thank you, Dr. Gong, for being here. Thank you.
Yeah.
Thank you, everyone. Thank you so much.
Thank you.
Thank you for inviting me.
Yeah.
Thank you.
Good night.
Yeah.
Yeah.
Good night.
Thank you, Sujal bhai.
Thank you, Mohit.
Yeah.